At birth, a human ovary contains up to 2 million primordial follicles. These are microscopic structures, each housing an immature egg cell locked in a dormant state since fetal development. Together, they constitute the entire ovarian reserve. This area chart plots the trajectory of that reserve. From its peak during fetal development, the primordial follicle count undergoes a steady, non-renewable decline. By puberty, the pool has already dropped to roughly 400,000, continuing to deplete exponentially until the supply is exhausted at menopause. Throughout the female reproductive lifespan, the ovary must strictly govern this limited supply. It continuously meters the activation of these dormant follicles. During each menstrual cycle, a select group begins to mature, but ultimately only a single egg is ovulated, while the remaining activated follicles undergo programmed cell death, known as atresia. This highly restrictive selection process operates across two distinct phases of development, the gonadotropin-independent phase and the gonadotropin-dependent phase. As follicles transition between these two phases, their cells secrete specific biological markers. By measuring the concentration of these markers, clinicians can accurately calculate the size of the remaining, invisible primordial pool. Mapping the biology of these two phases and their specific biomarkers provides the exact data needed to predict an individual's reproductive window and mathematically adjust fertility outcomes through assisted reproductive technology. Understanding this continuous developmental timeline is the required baseline for diagnosing early follicular depletion and ensuring long-term reproductive viability in clinical practice. The life cycle of an egg begins with recruitment, the moment a primordial follicle breaks its dormancy and initiates active growth. In its earliest stages, up to what is known as the small antral stage, this growth is completely isolated from systemic endocrine signals. It occurs independently of the gonadotropins secreted by the pituitary gland in the brain. During this independent phase, the follicle undergoes distinct anatomical changes. The most critical is the rapid multiplication of granulosa cells, which form a dense, protective, and functional layer surrounding the oocyte. This cross-section of a pre-antral follicle highlights the granulosa cell layer. As these cells multiply, they synthesize anti-Mullerian hormone, or AMH, creating a localized chemical barrier. This barrier suppresses the activation of adjacent primordial follicles, keeping them locked in their dormant state. Without the continuous, localized inhibition provided by AMH, the entire ovarian reserve would spontaneously activate and deplete in a catastrophic mass event. AMH performs a second gatekeeper function as the active follicle grows. It chemically reduces the developing follicle's sensitivity to follicle-stimulating hormone, dictating exactly when it will eventually respond to systemic signals from the brain. The gonadotropin-independent phase creates a slow-growing holding area of small antral follicles. Their progression is strictly metered by local AMH production, entirely divorced from the broader endocrine system. Once follicles reach the larger antral stage, control shifts from local ovarian signaling to the systemic endocrine system. This marks the beginning of the gonadotropin-dependent phase. Follicular survival is now entirely contingent on signals generated by the anterior pituitary gland. This chart illustrates the FSH threshold concept. Rising follicle-stimulating hormone crosses the survival threshold, triggering rapid expansion in a cohort of antral follicles. The largest dominant follicle outputs extreme estradiol and inhibin, crashing systemic FSH levels, which causes smaller, subordinate follicles to undergo atresia. The single dominant follicle survives this crash in FSH supply exclusively because it has acquired a superior density of FSH receptors. This allows it to maintain extreme sensitivity to the hormone even as systemic levels drop. Simultaneously, luteinizing hormone, or LH, stimulates the outer theca cells of the follicle to produce androgens. These androgens cross into the granulosa layer, serving as the required chemical substrate for continued estrogen synthesis.
A massive mid-cycle surge in LH triggers the final pre-ovulatory maturation of the dominant follicle, culminating in its rupture and the release of the egg. Natural dominant follicle selection is a physiological starvation mechanism. The most robust follicle simply cuts off the gonadotropin supply to its competitors. The clinical challenge in reproductive medicine is that a patient's true ovarian reserve, the dormant primordial pool, is entirely invisible to modern medical imaging. To evaluate a patient's fertility, clinicians use a physiological workaround. By measuring the intermediate pool of small antral follicles, they can reliably infer the total size of the hidden primordial reserve. This graphical representation of a transvaginal ultrasound demonstrates the primary visual diagnostic method, the antral follicle count, or AFC. It isolates and tallies the dark, circular fluid-filled sacs within the ovary that measure between 2 and 10 millimeters in diameter. For high diagnostic accuracy, the AFC assessment is strictly timed to the early follicular phase, typically performed between days 2 and 5 of the cycle. The biochemical equivalent to the ultrasound count is a serum AMH test. It measures the concentration of anti-Müllerian hormone in the blood. This 28-day cycle line graph shows why AMH is highly reliable. While estradiol and FSH wildly fluctuate in response to the cyclical dominant follicle, AMH presents as a flat, continuous line because it is secreted by the stable background pool of small follicles. Endocrinologists define diminished ovarian reserve using precise thresholds, an AMH level below 1.0 nanogram per milliliter, combined with an AFC showing under 5 to 7 follicles. AFC and AMH translate abstract physiological phases into actionable clinical data, providing a high-fidelity snapshot of a patient's remaining reproductive timeline. In vitro fertilization, this biological system is pharmacologically manipulated. Controlled ovarian stimulation is the deliberate overwriting of the ovary's natural single follicle starvation mechanism. Returning to the FSH chart, this demonstrates the pharmacological mechanism. By administering daily injections of exogenous FSH, clinicians keep systemic levels artificially elevated above the survival threshold. Because the supply never crashes, the entire subordinate cohort is rescued, growing in parallel to pre-ovulatory size. The total count of mature follicles successfully retrieved following this protocol is defined clinically as the patient's ovarian response. Safely managing this response requires strict individualization of the exogenous FSH dosing prior to treatment. Patients classified as poor responders risk cycle cancellation due to inadequate follicular growth. To force the remaining follicles past the threshold, these patients often require maximum allowable gonadotropin doses. Conversely, excessive responders face a severe medical risk of ovarian hyperstimulation syndrome if their robust cohort is overstimulated. They require drastically reduced FSH doses to ensure safety. The baseline measurements of AMH and AFC dictate exactly which stimulation protocol a reproductive endocrinologist will assign to a patient. The success of assisted reproductive technology relies entirely on hacking the FSH threshold, forcing a system designed for single-egg exclusivity to operate for maximum yield. Folliculogenesis acts as a highly restrictive biological filter. It manages a finite primordial reserve through a slow, gonadotropin-independent waiting period, followed by a fierce gonadotropin-dependent selection phase. AMH and the antral follicle count operate as the measurable bridge across this system. They allow clinicians to infer the size of the hidden primordial pool by observing the active intermediate stages. Modern reproductive endocrinology relies entirely on mapping and then exploiting the negative feedback loops inherent in this design. A thorough comprehension of these interconnected molecular, anatomical, and clinical pathways provides the exact mechanisms required to safely optimize fertility outcomes in assisted reproduction.